Hello everyone, welcome to part 3 of the module on neonatal hypoglycemia. Here I'll be dealing with the management of hypoglycemia in newborn. Introducing myself, I'm Dr. Rani Bashir, Senior Consultant Neonatology at Renai Medicity, Kochi. In my talk, I'll be dealing with the principles of management of hypoglycemia, management of asymptomatic as well as symptomatic hypoglycemia, including hypoglycemic seizures, IV therapy, calculation of glucose infusion rate, target blood sugars, some practical tips, recurrent or resistant hypoglycemia and its causes, investigations including critical sampling, diagnosis of hyperinsulinism, drugs used in resistant hypoglycemia, follow-up and outcome of hypoglycemia. Now, there are 4 basic principles in the management of hypoglycemia in newborn. First of all, we need to prevent symptomatic hypoglycemia in at-risk babies. Number 2, to correct blood sugar levels in symptomatic patients. Number 3, to avoid unnecessary treatment of newborns with physiologic low blood sugar levels during the transition phase from intrauterine to extrauterine life, because this will usually self-resolve without any intervention. And lastly, to identify newborns with a serious underlying hypoglycemic disorder. Now, how do you manage infants with asymptomatic hypoglycemia? Glucose water feeding is not recommended. Direct breastfeeding is the best option. If baby is not sucking, expressed breast milk may be given through an orogastric tube or Paladay feeds. Breast milk promotes ketogenesis, and ketone bodies are alternate sources of energy for the brain. If EBM is not available, formula feeds may be given. Recently, 40% dextrose gel at a dose of 200 mg per kg applied to the buccal mucosa is shown to prevent, treat, and reduce recurrence of hypoglycemia in at-risk babies, as well as transition to exclusive breastfeeding by 2 weeks of age. The take-home point would be, there is no routine monitoring of blood sugar in asymptomatic term babies without any risk factors. If you see the AIMS protocol 2019, if the blood sugar level is between 20 to 40, baby is offered a trial of oral feeds, either through direct breastfeeding or expressed breast milk or formula, and the blood sugar is repeated after 1 hour. Here we have 2 scenarios. Either the blood sugar is more than 40 or the blood sugar is below 40. If the repeat blood sugar is above 40, baby goes in for 2 hourly feeds with blood sugar monitoring 6 hourly for 48 hours as per the AIMS protocol. Target blood sugar mentioned is 50 to 120 milligram per deciliter. But if the repeat blood sugar is below 40, that baby need to be started on IV dextrose and managed like a case of symptomatic hypoglycemia. Now, if the blood sugar is below 20, baby is started on IV dextrose with a glucose infusion rate of 6 milligram per kg per minute, and subsequent management is as per symptomatic hypoglycemia. Now, when do you start IV therapy in hypoglycemia? There are certain indications. If the infant is not able to tolerate oral feeding, or if the symptoms of hypoglycemia persist after feeding, including hypoglycemic seizures, or if the oral feedings do not maintain normal glucose levels, or in cases of severe hypoglycemia, especially when the blood sugar is below 20 milligram per deciliter, IV therapy has to be initiated. In these cases, usually the baby receives a bolus of 10% dextrose water at a dose of 2 ml per kg infused over 1 minute. This is equivalent to 200 milligram per kg of glucose. Always a bolus should be followed by a continuing therapy at a glucose infusion rate of 6 to 8 milligram per kg per minute. Now, how do you calculate glucose infusion rate? I have given 3 formulas to calculate the glucose infusion rate. If you know the percentage of dextrose being infused, rate of infusion in ml per hour, and the baby's body weight. Or you can also have the ml per kg per day of IV rate with the percentage of dextrose. You can use any of these formulas to calculate the glucose infusion rate. What about the oral feeds? Breast milk sugar content as well as term formula sugar content can be taken as roughly 7.1 gram per 100 ml. Preterm formula sugar content is slightly on the higher side, which is roughly 8.5 gram per 100 ml. When we calculate using these values, we assume that all oral feeds are absorbed, which practically we know that doesn't happen. There is an excellent online glucose infusion calculator based on in the New Zealand guidelines website, ADHP website, which probably I can share the link in the discussion group. This incorporates both the IV fluid GIR as well as the glucose infusion from the oral feeds. Now, once you give an IV bolus, blood sugar has to be rechecked after 30 minutes and then hourly until the blood sugar is more than 50. If the blood sugar stays below 50, increase GIR at steps of 2 milligram per kg per minute every 30 minutes until it reaches 12 milligram per kg per minute. At a GIR of more than 12 milligram per kg per minute, the baby needs to be referred to a specialist center with pediatric endocrinology backup for further workup of the cause of resistant hypoglycemia and initiate drug treatment. Oral feeds will be initiated and continued throughout the treatment. If 2 consecutive pre-feed blood sugar values are more than 50, we can safely increase the feeding and taper GIR at 2 milligram per kg per minute every 6 hours, up to 4 milligram per kg per minute. Once GIR of 4 milligram per kg per minute is reached, oral intake is adequate and the blood sugar values are consistently more than 50 milligram per deciliter over 3 feeding fast cycles, then IV infusion can be safely stopped. According to the recommendations from the Pediatric Endocrine Society and American Academy of Pediatrics, which has come out in 2015, blood sugar targets varies based on the age of the baby. In the first 48 hours of age, target blood sugar more than 50 milligram per deciliter. After 48 hours of age, it is more than 60 milligram per deciliter. And the maximum blood sugar which we should aim at is 90 to 100 milligram per deciliter. The target is slightly higher for babies with suspected or confirmed genetic hypoglycemic disorder. Here the plasma sugar should be maintained above 70 milligram per deciliter. Some practical tips on managing babies with hypoglycemia. Please ensure continuous glucose infusion, preferably using an infusion pump and without any interruption. Do not stop glucose infusion abruptly, as severe rebound hypoglycemia may occur. Through a peripheral vein, the maximum concentration of dextrose that can be infused is 12.5% because of the risk of thrombophlebitis. If the baby needs more than 12.5% dextrose, umbilical lines should be inserted, and we can use up to a maximum of 25% dextrose through a high or a normal position of umbilical line or UVC. If there is persistent hypoglycemia, check if IV line is functioning, recheck the IV fluid preparation as well as the infusion rate. Let us move on to recurrent or resistant hypoglycemia. We call the hypoglycemia as resistant hypoglycemia or persistent hypoglycemia when the baby fails to maintain normal blood sugar in spite of a GIR of 12 milligram per kg per minute, or stabilization is not achieved by 7 days of therapy. Most common cause is hyperinsulinism. Hyperinsulinism can be of two types, congenital and acquired. Congenital causes can be due to mutations affecting regulation of insulin secretion from pancreas. Acquired causes include maternal diabetes, birth asphyxia, severe intrauterine growth retardation, Rh incompatibility, polycythemia. In such cases, when blood sugar falls below 40 milligram per deciliter, critical samples should be drawn to identify the cause of hypoglycemia, which is persistent. This includes insulin, cortisol, growth hormone, beta hydroxybutyrate and free fatty acids, and urine for ketones. What are the causes of recurrent or resistant hypoglycemia? Broadly, we can divide it into two causes. Hyperinsulinemic hypoglycemia, meaning the type with high insulin levels, and normoinsulinemic hypoglycemia, meaning where the insulin levels are normal. For hyperinsulinemic hypoglycemia, apart from the congenital and acquired causes I mentioned, among the congenital causes include certain channelopathies like potassium ATP channel defects, glutamate dehydrogenase activating mutation, glucokinase activating mutation, short chain 3-hydroxyacyl-CoA dehydrogenase mutation, and Beckwith-Wiedemann syndrome. For people who have seen babies of Beckwith-Wiedemann syndrome, these are overgrowth syndrome where we have large for gestational age babies with visceromegaly, umbilical hernia, omphalocele, specific nevi, and severe resistant neonatal hypoglycemia. And these babies are prone for Wilms tumor and other hepatoblastomas later in life. Now coming to the normoinsulinemic hypoglycemia. Normoinsulinemic hypoglycemia means here the insulin levels are normal. One is due to the counter-regulatory hormone deficiency. Dr. Jacob Abraham had mentioned the counter-regulatory hormones which act in blood sugar homeostasis. This could be cortisol deficiency, which can be central or adrenal, like hypopituitarism, congenital adrenal hyperplasia, or growth hormone deficiency. Inborn errors of metabolism also come under normoinsulinemic hypoglycemia, like glycogen storage disorders, organic acidurias, galactosemia, and hereditary fructose intolerance. I already mentioned the investigations for resistant hypoglycemia. This gives a comprehensive, extensive list. As baseline, normally we get a blood gas for the baby, which gives you your bicarb, lactate levels, and we also get the basic hormone workup like insulin, cortisol, growth hormone levels, and also ketone levels like beta hydroxybutyrate and free fatty acid levels. Other investigations comes as second line based on the results of these first line investigations. Now, how do you diagnose hyperinsulinism? We call it hyperinsulinism when the detectable insulin level in blood is more than 2 MIU per liter. So usual value in hyperinsulinism is 5 to 10 MIU per liter. So if the insulin level is above 2, if the free fatty acid levels are low, that is below 1.5 millimoles per liter, ketone levels are low, that is plasma hydroxybutyrate level is below 2 millimoles per liter, and when there is an inappropriate glycemic response to 0.1 milligram per kg IM glucagon at the time of hypoglycemia. Normally, when you give glucagon IM, 0.1 milligram per kg, within 20 minutes, the blood sugar values rise more than 30 milligram per deciliter. When this glycemic response is inappropriate, we call it hyperinsulinism. So just to summarize, when the detectable insulin is more than 2, when the free fatty acid levels and ketone levels are low, and when the glycemic response to IM glucagon at the time of hypoglycemia is inappropriate or insufficient, we call it as hyperinsulinism. Now, what are the drugs used in resistant hypoglycemia? Hydrocortisone, diazoxide, octreotide, glucagon. These are the main drugs which are used in resistant hypoglycemia. Of these, diazoxide and glucagon are not used in small for gestational age infants. Now, talking about hydrocortisone, I will not suggest you to learn by heart the drug doses in neonatology. It is always ideal to refer to drug dosing books like Neofax before any drugs are prescribed. It is a good idea to cross-check the doses which the doctors prescribe as well. So for completion's sake, hydrocortisone is given at a dose of 5 milligram per kg per day in 2 divided doses, orally or IV. Mode of action is by reducing peripheral glucose utilization, increases gluconeogenesis, and increases glucagon effect. As you know, steroids are not without side effects. The main side effects are hyperglycemia and hypertension. Diazoxide, oral, 5 to 15 milligram per kg per day in 3 divided doses. It is a potassium channel agonist. Side effects are fluid retention, hypertrichosis, and cardiac failure secondary to fluid retention. So commonly, hydrochlorothiazide, which is a diuretic, will often be prescribed along with diazoxide. Octreotide, given as subcutaneous or as infusions, It is a somatostatin analog which inhibits insulin secretion. Side effects are cholelithiasis, transient growth impairment, and tachyphylaxis. Glucagon, 0.2 milligram per kg, subcutaneous or IM. It can even given as an infusion. Acts by glycogenolysis and increased gluconeogenesis. Always, when you reach the stage of giving IM glucagon, make sure you secure a stable IV access, and it should be followed by IV infusion of dextrose with a good GIR of 6 to 8 milligram per kg per minute or above. Side effects include nausea, vomiting, skin rash, and rebound hypoglycemia. Hence, securing a stable IV access for continuous IV dextrose infusion is very important. Other management options for completion's sake is mTOR inhibitors like sirolimus, which is in the experimental stage. Surgical options like near total pancreatectomy if infants are not responding to medical treatment. Prior to this, we need to rule out any focal lesions in pancreas through the specific PET scan. Now the last slide of the neonatal hypoglycemia management talk. So the typical pattern of brain injury in babies who suffered hypoglycemia is in the parieto-occipital cortex and subcortical white matter. And this can be diagnosed by MRI brain. But we don't have a clear data which defines the blood sugar value or the duration of hypoglycemia which causes brain damage detectable by MRI, or the blood sugar value and duration of hypoglycemia which lead to long-term neurologic sequelae. Close follow-up of neurodevelopmental status is warranted. Thank you for your patient listening. And any doubts or clarifications, we can discuss in the chat box. And I take this opportunity to thank the organizers of this online training module, NNF Kerala and NNF Pathanamthitta, for giving me this opportunity. Thank you.